Good afternoon. I have no financial interest in this product, and I think none of my accompanying persons, experts at the panel. We have no financial interest. I came to know Marco Lombardo a few years ago. I have read an article, his article on cross-linking, dealing with basic science. And you know, all these controversies in cross-linking on the methodology, how to use it, which energy, epi on, epi off, pulse, accelerated, they confuse you. And you go to the basic science. And the basic science also confuses you because you have also contradictory results in the articles regarding the basic science. I liked very much his article, and I passed in Barcelona among the exhibitors, and I saw this theranostic device. And I thought, okay, it's additional machine, additional company. And I asked, who is behind this machine? And they told me Marco Lombardo. When they told me Marco Lombardo, I took off my hat, gave respect, and decided to know more about this technology. And I think he can present it better than us. Please, Dr. Marco Lombardo.
Thank you very much, Dr. Adel, for your kind words. You always promote me. So, in the next 15 minutes, I will tell you a story. The story of theranostic development, where myself and my brother Giuseppe embarked many years ago. So first of all, start from the meaning of theranostics. Theranostics is a combined word of therapy and diagnostics. In the field of keratoconus, UV light-triggered theranostics enables riboflavin to act both as the therapeutic agent and the diagnostic dye. In principle, a UV theranostic device uses the same UV light source both to photoactivate riboflavin and to measure its concentration in the cornea and estimate treatment effect. But the question is, was there really a need to introduce a new technology in corneal cross-linking for treatment of keratoconus? According to the literature, and as we have been using corneal cross-linking since 2004 for halting disease progression, the effect of this technique remains uncertain, because by looking at clinical data from randomized studies, we see that efficacy intended as flattening of the Kmax ranges between 10 and 90% among studies. So the question is, why so much variability? And as a clinical implication to this question is, when I indicate corneal cross-linking to one of my patients, what could I say to this patient when effect by the literature is like to flipping a coin? And so we made a lot of studies understanding what variables were behind so much variability. And we defined three main chapters. The first one regarding the number of products, protocols, the expertise of the surgeon performing treatment, the unclear instruction for use from manufacturers. The other, very important, is that there is no keratoconus like the other. And the third one is the lack of understanding on the photochemistry between UV light and riboflavin into the cornea. So we dived into this field with the scope to identifying and solving each of the above variables. First of all, focusing on the interaction between riboflavin and UV light in the cornea. Basically, the principle of operation of corneal cross-linking is almost well known. We have a photoinitiator, which is the riboflavin, a photoactivator, which is the UV light. As the UV light irradiates the cornea, it generates electrode donors, principally riboflavin triplets, which in turn are responsible for the photopolymerization process, generating new chemical bonds among the corneal proteins. But this process is much more complex than thought. If we rely only on empirical opinion, we could really compromise safety and efficacy of corneal cross-linking. Here there is an example. You see a plot where in the x-axis you see the corneal depth. You see a dotted line representing the safety threshold as defined by Wallensack many years ago. And then you see different curves with different colors representing different riboflavin concentration from 0.01 to 0.22. If we look at the vertical black arrow indicating 400 microns, we can see that the red curve representing 0.03% is the riboflavin concentration we need to safely irradiate 400 microns using 5.4 energy dose. But what happens if I increase my energy dose? With 7.2, we need 0.06, the double of concentration. If I increase to 10, I need 0.08. So actually, we can understand that we were acting as crazy doctors. We could not talk about thin corneas or higher radiance protocol if we don't know how much riboflavin is enriching our tissue. This is why we performed several experiments treating hundreds of eye bank donor tissues, measuring exactly the amount of riboflavin permeating the cornea prior to irradiate the cornea, and the amount of riboflavin photoactivated during irradiation, with the intent to correlate all this data with the biomechanical strengthening measured at different levels of observation, using different techniques from atomic force microscopy, surface force apparatus, a dynamic tonometry device when using wool-like globes. And at the end, we were able, by measuring riboflavin concentration intraoperatively during soaking phase and during UV radiation phase, to predict with 94% accuracy and precision the effect of corneal cross-linking. Each of our steps has been published in leading research journal, and I invite you, if you want to know more, to go reading this paper. So before entering the clinical scenario, we were well aware on how to improve the reproducibility of our results, mainly on how to predict whether we were really effective when performing cross-linking in our patients. Basically, thinking about to meet two main issues: to deliver an adequate amount of riboflavin into the cornea prior to irradiate the tissue, and second, ensuring that we were effectively photoactivating the riboflavin into the cornea stroma. And so, at the time we started the ARGO trial in April 2022, the Cochrane Eyes and Vision was publishing a new meta-analysis studies pointing towards theranostics as likely the opportunity to understand what was the main factors limiting the efficacy of this technique. And basically, the question of the trial was really simple. Is cross-linking really effective in halting disease progression? Our hypothesis was that riboflavin would be the primary factor in determining the clinical efficacy of the technique. And at the end of the trial, we were also able to publish the outcomes in ophthalmology. And I invite you to read to know more, and I would only summarize the main outcome of the trial. So basically, the primary outcome of the trial was to validate the combined use of theranostic biomarkers, including the riboflavin score, which is an estimation of riboflavin concentration, and the theranostic score, which is a function defining how much riboflavin is photoactivated and what will be our treatment effect, in predicting the Kmax flattening at 1 year after treatment. So, in order to abate the uncertainty of treatment, we stratified patients with documented disease progression in 2 protocols. This in order to validate the technology regardless of the protocol chosen by the doctor. And the trial was designed as a multi-center trial in order to improve the generatability of the results. We included in the trial 50 patients with progressive keratoconus, and 47 completed the 12 months follow-up visit. And during the trial, the investigators were not aware about the threshold of the riboflavin score and the theranostic score that we used to design the study protocol and that we defined in preclinical laboratory studies. For the riboflavin score, we had to go above 0.4, and for the theranostic score, we had to reach at least 0.6. And by analyzing data, we were able to predict Kmax flattening with 91% accuracy and 95% precision with the combined use of the theranostic biomarkers. Of note, when analyzing data in the stratified group and looking at the true positive, we were also able to understand how much effective was the epion under theranostic guidance. Indeed, the average flattening was equivalent, almost the same as the state-of-the-art epi-off technique, and more than 4 times effective than state-of-the-art epi-on. So, in order to answer to the question, is cross-linking really effective? We can say yes, because with theranostics, we now have the opportunity to assess intraoperatively what we are doing in the cornea of our patient, and we can predict with high accuracy and precision the therapeutic benefit of this technique. And what about the hypothesis of the study? The answer is yes. The intraoperative monitoring of riboflavin concentration is really the pillar to the effect of corneal cross-linking. I want to briefly show how does theranostic-guided corneal therapy work in order then to go to discussion with the esteemed panelists. Mainly, theranostic-guided corneal cross-linking has 4 main steps. The first one is focusing using the integrated Placido disc, then to measure the baseline fluorescence of the corneal tissue. The third one is the application phase, and during this phase, the machine will provide you with the riboflavin score. And then the UV light therapy phase, where the machine will calculate the theranostic score, estimating treatment efficacy. Here you see some screenshot from the machine with the green bar representing the riboflavin score. As we go forward the application phase, you see more intense green fluorescence with the riboflavin score increasing. If we do not reach the 0.4 threshold, the device will not allow you to proceed to UV radiation. This is most important in order to avoid the risk of treatment failure. If, in the other case, we are above this threshold, the machine allows you to proceed to irradiate the cornea, and during the UV light therapy phase, we see the theranostic score showing how, as we will photoactivate the riboflavin, with the riboflavin score decreasing, the theranostic score will increase. If at the end of your preset time we do not reach the 0.6 threshold level, the machine will provide you with 15% more energy in order to get the result and ensure yourself and your patient about the therapeutic benefit of the technique. Here you see the telemetry, what really the system does during treatment, tracking and recording all data about riboflavin dosing, about the treatment efficacy, and also about the UV light irradiance and energy. Because what is really important is that we must ensure that what we have set to deliver to the cornea is really made by the instrument. This is the same patient as for the telemetry. It's a very young guy treated with the EPI-off technique. You see a 1 year significant flattening with also a visual acuity improvement. This is also another very young guy treated with the EPI-off, and this is a demonstration of how early detection and precision medicine can not only halt disease progression, but improve the quality of life of our young patient. Indeed, in this case, after 6 months after treatment, the topography algorithm cannot understand anymore that this is a manifest keratoconus. If we want to look some other data on EPI-on, here we have a 27-year-old patient, and this is for Adel, whether we see not very big flattening, but we see a very nice regularization of the anterior cornea with a significant improvement in corrected distance visual acuity. This is another case on epithelium on. Here we have general flattening and regularization of all the anterior cornea with also significant corneal flattening and significant improvement in visual acuity. So to conclude, the question is, we are now entering in a new paradigm for treating keratoconus with riboflavin and UV light. Actually, with theranostics, we can understand what were the reasons for so much variability among products, protocols, and so on. Here, for example, different riboflavin products measured with the theranostic device, evidencing how not only in EPI-on protocols, but also in EPI-off protocols, we do have a huge variation among different products. The basic mechanism of theranostics is to abate the risk of treatment failure because we cannot irradiate the cornea without reaching the threshold. But for EPI-off, this means that we can ensure that we protect the cornea from an excessive UV light exposure. Here, another reason why we are entering in a new paradigm, here there are 2 different eyes treated both with the EPI-on, so with the epithelium intact, but using different energy doses, 5.4 on the left, 3.6 on the right. By the way, following the measurement of the theranostic score, we can predict in both cases a significant Kmax flattening and significant improvement in visual acuity. So to conclude, I would like now to make this example. We were used before theranostics to place UV light at the center of the corneal cross-linking galaxy. Now we place riboflavin, and this is more or less like the Copernicus theory. placing the sun. We place not the light, but the riboflavin at the center of our galaxy. And this is why we are opening a new world of treating our patient with precision and predictive medicine. Thank you for your time, for your attention.
Hello. Can you tell us about your experience with epi-on cross-linking, and do you have a riboflavin that penetrates better the cornea, and if you have measured that, because
yes.
It's challenging all the question of absorption
yes.
of riboflavin into transepithelially.
Yes, indeed, I have shown the ARGO trial results. I did not talk about riboflavin formulation, which has been totally formulated by our team, according also to our experience. Because, yes, theranostics help making treatment predictable. But in case you are using products that are not so efficient, you will never end the treatment. So we formulated a high concentration riboflavin formulation, including multiple phosphate buffer in order to increase stability. This is 3 years expiry date. You don't need to place in the refrigerator. And it is highly hypotonic, 100 millismol, in order to allow the riboflavin to be sucked inside the stroma. And as an answer, there is a high concentration of sodium chloride at pH 7. This is the reason why the formulation has been developed for all types of protocol. Epi-off, no dextran, no ipromelos, so no corneal thinning. Epi-on, highly hypotonic, a lot of enhancer, and iontophoresis. I will talk tomorrow on that, because it is highly negatively charged.
Okay, a question, please. Yeah, does oxygen play a role in the procedure using the theranostic with the riboflavin?
This is a very good question. I also thought about that, because this is another variable. As we mentioned a little bit during the talk, during corneal cross-linking, we have mainly two photochemical processes. Type 1, which is based on riboflavin triplets, and type 2, which is based on the generation of reactive oxygen species. Actually, in chemistry, when we have a photochemical reaction, the nature always makes the favor to the substrate that is much more concentrated. By the way, during all our preclinical studies, we evidenced that when we can reach appropriately the cornea, so we are above the 0.4 riboflavin score, all the photochemical reaction is explained by the concentration of riboflavin, because the decay is said is pseudo-fist order. What is changing is the higher the concentration, the steeper the consumption, the photoactivation, which is also a point that allows us to create the patterned delivery of riboflavin in also to spatially control the photopolymerization process in order also to control the improvement in optical quality. The oxygen, in this case, cannot be measured. What are the main limits in oxygen is that, first of all, oxygen is not soluble in water, and the cornea is 70% made of water. And even if you pump the oxygen on the cornea, when the oxygen encounters such a photooxidative environment where the UV light encounters a lot of riboflavin, creating a lot of electron donors, this oxygen is immediately created in oxygen singlets, which is the fastest chemical reaction in the nature. So even if you pump oxygen, it will just last in the few first microns of the cornea. By the way, what we could propose is to measure the flow of oxygen, make a controlled study with and without homogeneous patients, so block randomization or whatever, in order to have same baseline age and Kmax, and see the results 1 year after.
Okay, thank you so much, Marco. This was really amazing. I just have a few questions. How much energy are you using? What's the fluence?
Actually, in the ARGO trial, we only use 5.4 joule.
Okay.
In the machine, we have full range from 3.6, 5.4, 7.2, and 10.0 joule. But
what do you recommend?
Actually, we recommend 5.4 because we have hundreds of clinical data on that. We made a preclinical study also looking at the interaction between different irradiance and different energy. So actually, in the preset protocols, we have one at 3.6 and all the other at 5.4. But as we will collect more data in control studies, we can understand how to additionally introduce other protocols.
Okay, now the common consensus is that if you leave the epithelium, this will block a little bit of the UV light. So my question is, since you do have an intact epithelium, or this is your recommendations is always...
In this case, when you will choose one of the preset, inside the machine there is the enhanced epi-on algorithm, which increases automatically of 10% the irradiance and energy. So 5.4 is 5.9.
Okay, so if you use this, my question is, if you are going to use an epi-on and you decide to do, the machine gives you 5.4, and then what's the next step, 7.2?
7.2.
If you use a 7.2, will this result in a higher theranostic score? This is my question.
No,
have you seen this?
It depends from the amount of riboflavin before starting irradiation.
Yeah, if you have the same riboflavin score, would
Yes.
it end up with a more theranostic score?
Actually, I can say you, the higher irradiance, the lower the photoactivation.
Oh,
In
really?
order to get a very good theranostic score, we need to consume at least 50–60% of the riboflavin inside the cornea. The higher the irradiance, the lower the consumption.
So
Because
this is something. I mean, this
photokinetics,
is a very important piece of information. So the higher the irradiance, the smaller amount of riboflavin that is photoactivated.
The low Bunsen-Roscoe is only true between 3 and 11 milliwatt. Otherwise, the photokinetics is non-linear. We have a lot of data on that. We need to study and now to replicate in clinical.
So long as you are having a high riboflavin score, let's say 0.6, 0.7, whatever, then you will be more than happy using a low fluence like the 5.4.
Relative, 5.4.
And you will have a higher theranostic score with this. This is
Yes.
This is
For how long the 5.4? For how long?
This is the protocol are 10 milliwatt or 18 milliwatt or 3 milliwatt.
So you are
you
talking
can choose
about the
the irradiance.
Okay, okay.
But higher irradiance are not...
So yes, so what about a high irradiance? What is the sweet spot? Which is the best protocol that you use to utilize the highest theranostic score that you can have?
But actually, we have hundreds of data with 5.4 and between 3 and 11 milliwatt. And
so the 9 milliwatt, is it okay?
Yes.
9 for 10?
Yes.
Okay.
Can I say something? Yes. You know, I'm thinking what I am learning from your lecture, you know, and we are, and in continuation to all the controversies regarding cross-linking and the tens of protocols and the many variables, okay? I remember a little bit the philosophy of Stoicism. Miltos, Stoicism, you know Stoicism. You didn't mention it, okay? And you know, it's a Greek.
Stoicism is on the other side of it.
Yes. So it started here in Greece, you know, and you had an emperor, Marcus Aurelius, who was a Stoicist, and he wrote a book, the Meditation. And this philosophy tells you that if you have a problem, something that you can't control, okay, so leave it and do put all your energy with things that you can control, okay? This is one of the pillars of this philosophy. And in cross-linking, we can't control the intervariability between the corneas, between the persons, between the patients. This you can't change the patient. And in the cornea, we have intra-variabilities, like where is that weakest point, all these biomechanics that we don't know a lot about it. And then comes the riboflavin and the radiation and the chemical process itself that we can't see, we can't measure it. What I deduce from your work is that you take us a step further in controlling one of the variables, which is very important, the variable of the concentration of riboflavin into the cornea. And there is your force, here is your strength.
Yes.
Am I understanding right or not?
Yes, because also before you start your treatment, you need to insert all data on the cornea and the refraction. And accordingly, since the theranostic algorithm is a machine learning algorithm, with the follow-up data, we can instruct supervising the algorithm to improve performance. So apart from saying precision predictive medicine, I like to say this is data-driven medicine.
So, as Adel told us here now, you know, you can control, okay? But I cannot imagine how are you controlling it actually? How are you measuring, you know, that the cornea now is fulfilled or all soaked with riboflavin, and how can, you know, you can measure that irradiation have done the job? Because in your presentation you mentioned here that, you know, the machine can stop by itself if all the riboflavin in the cornea is vanished and the cross-linking have been already performed.
Yes, basically you shall think about the device as a fluorescence microscopy. So in this case, here is represented how the algorithm works, because as you illuminate the cornea that has been enriched with riboflavin, you excite riboflavin that by nature emit a green fluorescence. So we calibrate each device according to the work done in preclinical, that each green pixel has an intensity. Each of those intensities corresponds exactly to a determined riboflavin concentration.
Yes, sure.
Thank you very much, Marco, for brainstorming us, because you're making a real revolution. Two quick questions. The first one, we now know the end point, which is the concentration measured by the hue or the saturation. But again, what is the end point for your achieved target? Is it again the consumption? I mean, when you reach a certain consumption, so you reached what you need?
Both, because in the trial we talked about combined use. You need the riboflavin score to go above 0.4 and the theranostic score to be at least 0.6. So it's the combination of these data that makes your treatment predictive of the
Excellent.
effect.
And is there any correlation between these two factors and the amount of flattening of diopters / the demarcation line, or we will forget about these?
We are measuring it, especially for EPION, because, as you know, the demarcation line is actually an imaging biomarker. We know that we cannot see in all our patients, neither in EPIOF, but since now we can predict treatment, we want to correlate these biomarkers that we can see, for example, the demarcation line at 1 or at 3 months, and then understand the meaning, the real meaning of the demarcation line, which is a change in the birefringence properties of the cornea, because you look at it with the OCT, which use infrared light, and is polarized.
This is the death of the keratocytes. So we will be one day say adios to the demarcation line?
It is not said, Shafik, because when we irradiate the cornea, we create is phototoxic. So all the keratocyte in the alpha anterior cornea disappear for apoptosis. So basically, for me, it's a change in the birefringence properties of the collagen proteins and the matrix adensation. But I cannot correlate it with the flattening, actually.
Thank you very much. This is really brainstorming. Thank you.
I have another question, if it's possible. What is the role here, just here? What is the role of epithelium in measurement of riboflavin concentration when it's soaked and when it's not soaked within the cornea? And what is the role of the iontophoresis during?
Yes, basically, Ramez, you consider that we make the measurement all over the volume of the cornea we are irradiating. So having or not the epithelium changes only the thickness that you shall include in the preset calculation of treatment. So it is not relevant. 40 microns more or less, according to your patient cornea. When we made preclinical studies, we were interested to know how much riboflavin was entrapped between the basal cells. And as we complete the soaking phase, and we are above 0.4, we recommend in the instruction for use to wash the surface of the cornea with a balanced salt solution in order to remove any eventual residual molecules in the epithelium. You are ensured that you will irradiate the stromal riboflavin, even in case if you want a number, it is less than 3% of riboflavin inside the cornea, so it's irrelevant. Just in 3 seconds, as you start irradiation, you photoactivate all riboflavin in the epithelium.
Thank you.
You're welcome.
Thank you.